Okay, let me, do you want me to just start with the intro?
Yeah, we are live also now.
Yeah, sounds good. Okay. Let's see here. Let me just share slides super quick. Okay. All right, Dr. Mercado, are you ready to go?
Yeah.
Okay, sounds good. Hi, everyone. Thanks for joining. This is the last session of the When to Worry series that we've been hosting pretty much throughout all of March, every couple of weeks. So the When to Worry series is a program brought to you by MAPS and MCRC and Muslim health professionals. It's a joint collaboration. Our goal is to bring together community physicians to speak about monitoring key symptoms of common healthcare conditions at home. When COVID-19 hit and hospitals and healthcare facilities were very overwhelmed, day-to-day symptoms of serious illness were definitely brushed under the rug and not given much attention. So we hope to help the community with indicators of, when to worry, as our title is, and how you should deal with symptoms. My name is Mariam, and I am a board member for Muslim Health Professionals, and I'll be moderating the session with Dr. Mercado. Dr. Mercado is a board-certified endocrinologist at the Overlake Hospital, and she is also a volunteer at the MAPS MCRC Community Clinic. She's also available by appointment every Monday through the clinic if anyone is interested in getting in contact with her. Dr. Mercado previously joined us to speak about diabetes and common symptoms, and today she'll be speaking to us about osteoporosis.
Hi, thank you for having me. Yeah. So I guess we'll start. Now, osteoporosis is not clearly an emergency, but I think it's really really not taken as seriously. But once somebody breaks a bone, it can be really quite difficult. And so I thought it'd at least spend time to at least help us recognize the gravity of osteoporosis and what we need to do. So I'm going to turn off my video so I can look at the slides, and then I will turn the video back on. So, all right, let's go with the first slide.
Yeah, I'll also be turning my video off, and if anyone has any questions or if anything comes to the chat, either myself or another person that will be moderating will be able to ask the questions.
All right, so first slide, please. Okay, so do I need a bone density test? Oftentimes I have patients coming into the office that are like in their 20s, wanting to get a bone density test. What is a bone density test? It's just basically a machine that measures how much mineral we have in the body, such as calcium. And it really has very little radiation. You basically just lie down on a table and a movable arm passes above you to scan your bones. And we do this to diagnose osteoporosis before you break a bone, and sometimes also helps us estimate your chances of breaking a bone in the future and to monitor the effectiveness of osteoporosis treatment. So the recommendations by our society is endocrine society is bone density is indicated in women that are postmenopausal, usually past the age of 65 years and older. Men actually can get brittle bone disease as well, but we don't usually just routinely do it. But if we do, if they have risk factors, we start getting a bone density at 70 years and older. Now, women that are 50 years old or to 64 years old with risk factors, which I will mention down the road, can also have a bone density test and don't necessarily have to wait when they're 65. And men that are in their 50s to 69, also with risk factors, can get a bone density. So sometimes in medicine, we just don't really want to get too many imaging if it's not really indicated because it's hard to interpret. So let's go to the next page. So I'm just going to really cut to the chase here. But when we look at a bone density, the bottom line that we look at is called the T-score. So T-score is really nothing like, it's just, let's say if we are going to put people in line with the same age as you, with people with a T-score of plus 1.0 on the right, meaning they have good bones, and a T-score of minus 3.0 on the left, meaning bad bones. It's just basically telling you where you are in that line. And so if your T-score is minus 2.5 and below, which means that you're at the bottom part and you've got a lot of people, more than 75% of people that have better bones than you. And it's just a cutoff that tells us that if you belong to the lower half, you'll have a higher risk of fracture, but you could still certainly fracture if your T-score is not minus 2.5. So, but this is what we as physicians just kind of teach our patients, that if your T-score is minus 1.0 or above, that's still good. If your T-score is minus 1.0 and 2.5, that means you're kind of in the borderline range. We used to say osteopenia, but now we say low bone mass. And then if your T-score is minus 2.5, that is osteoporosis. So it's just kind of like a way to just stratify patients, what their risks are of fracturing. And this is kind of like a way to put them in buckets to at least identify which one is at higher risk for fracture. Next slide. And so these are the risk factors that I was mentioning earlier. Certainly white women and Asian women are at higher risk for bone loss. So that's why white women and Asian women, if they're like maybe younger than 65, then the original indication that I've mentioned earlier, those are risk factors, especially if they fractured something, should have a bone density earlier than 65. Smokers and heavy drinkers, especially those people that drink more than 2 per day, are risk factors for osteoporosis. If you are slim, if you weigh less than 125 pounds, that is also a risk factor. History of bariatric surgery, those gastric bypass surgery, not the rubber band, what do you call that? The gastric banding, but the actual patients that actually have a portion of their stomach and their small intestines removed are at risk for osteoporosis because of malabsorption of vitamins. If you are a senior with a history of hip fracture, those are risk factors. If you have kidney failure, inflammatory bowel disease, such as Crohn's disease, rheumatoid arthritis, which is a connective tissue disorder, it's an autoimmune disorder like lupus, history of liver disease, or if you have an eating disorder, such as anorexia nervosa, these are also risk factors. And most importantly, we see a lot of these patients taking steroids, patients that have asthma, that are on high-dose steroids for months on end, people that are on thyroid hormone replacement, but are getting inappropriate high-dose thyroid replacement or too much levothyroxine, patients that have cancer that are on immunosuppressant drugs, and people that are on a blood thinner called Coumadin. So I think these are important risk factors to identify, that if you have these, and you don't necessarily have to be 65, but if you're like a woman between 50 and 64 and you have these risk factors, then we can get a bone density early. Next slide. So this is, I think, very important. And when I have patients come to me in the office, whenever I ask them how much calcium they take, they always tell me I take 1 tablet a day. But, this is the guidelines, and I'll tell you how to read labels on the next slides. But in general, women 50 and younger needs about 1,000 milligrams of calcium per day. 51 and older is 1,200. Men 70 and younger is 1,000, and men 71 and older 1,200. You don't necessarily have to take 1,500 of calcium a day. Too much calcium is not necessarily good for you either. Calcium is best obtained from the diet. And so next slide. I will go through this slowly. Reading food labels, I think this is very important. Sometimes when you read food labels, it'll say 30% of DV means the value of calcium on the label. That's equivalent to, if they say 30 milligrams of daily value of calcium, that's equivalent to 300. So whatever that percentage is, so 30, 20%, or 15, it's basically just saying 300 milligrams, 200 milligrams, or 150 milligrams of calcium. So because sometimes it's not going to really tell you how many milligrams, but it's going to give you the percentages. So that's one way certain calcium are labeled as. But another one is, next slide, please, is you see, so this is just a perfect example. Calcium citrate is best absorbed. I recommend calcium citrate because you can take it irregardless of food versus calcium carbonate. That's another form of calcium supplement you can get. But when you get a calcium supplement, when you read labels, you don't just look at the front like this slide right here. It just says, calcium and magnesium citrate. You have to look at the label at the back. Next slide. So, for example, this particular calcium citrate, you have to look at the serving size. So I said earlier in the 2 slides before, the guideline is 1,200 milligrams of calcium per day, typically. So we say, ideally, if you can, half of your dietary or your total calcium ideally should come from at least your tablets, and the rest should come from your diet. Of course, if we can get all of our calcium supplements through the diet, that would be better. But if you cannot do it in the diet, you can certainly get it from the tablet. But this is how you read the label. So it's important to see the serving size. So in this instance, this calcium citrate, 2 tablets will get you to 500 milligrams of calcium. So you don't just take 1 pill, you take 2 tablets to get you to 500, and then 2 tablets will get you to 800 international units of vitamin D3. And then you can then add the rest to get to the 1,200 milligrams total. So your diet plus in the tablet plus in the diet should equal 1,200 milligrams per day. So if you go to the next slide, you can see that these are some examples of dietary sources of calcium. If we can get all of our calcium from the diet to total at least 1,200 milligrams, that's great. So I've got several pages of this. So as you can see down here at the bottom, yogurt, a 6-ounce yogurt is already 300 milligrams. So if you get at least 2 yogurts a day, that'll get you to 600 milligrams of calcium. And then you can get another 600 milligrams of calcium from the tablet, that'll get you to 1,200. If you cannot have any dairy, then you have other sources here, but they're just not as much. So like kale, a cup is only 179, but I think this is a good resource. So if you go to the next page, you've got other sources here like cheese or even almond milk or calcium fortified orange juice, and 8 ounces of that is 300 milligrams. So really, if we drink juice in the morning, that's an 8 ounce, that's 300 with a yogurt, that's another container, that's at least another 6 ounce, that's 600 right there altogether. And then plus another 600 milligrams of calcium citrate, you're at 1,200 milligrams right there. So it's preferable if we can get it all from the diet, but if it's not possible, get it half from your diet and half from the supplement. But you don't really need to take 1,500 milligrams of calcium tablets. Diet is a better source. So I think these few pages that I've actually attached on my slide would be a good resource to at least get you an idea how much calcium is in the diet. Next slide. Oh, here's more. Oh, here you can even have mac and cheese or chocolate pudding or pizza. A serving of pizza is 115 milligrams of estimated calcium. Of course, it has fat, but next slide. Now, vitamin D. I usually say 1,000 to 2,000 IU vitamin D per day, but this is what is recommended. If you're age under 50, 400 to 800, 50 and older is at a minimum 800 to 1,000 per day. But some patients need more. But the safe limit is 4,000 IU per day. Now, there are some patients that are vitamin D deficient that we give 50,000 of vitamin D3, but that's only for a few months, and then we stop it, and then we have them take an over-the-counter daily vitamin D3. So this is vitamin D3, and too much vitamin D is not good for you. When we do vitamin D levels in the office, the goal vitamin D value, and I did not write it down in this slide, I apologize, is a value between 30 to 40. So that's how much vitamin D level we want it to be. And toxicity is if it's like above 100. So you do not need too much vitamin D. Sometimes I say in the winter and fall, you can maybe double your vitamin D because we don't get a lot of sun here in the Northwest. But in the summer and in the spring, since we get some sun, hopefully we're out and about, then you can cut your vitamin D3 tablets in half. Next slide. So I think patients always ask me what kind of exercises can help build strong bones. You know, you don't necessarily have to lift weights. Certainly it depends on what your capabilities are. High impact if you can do dancing or hiking or aerobics. But fast walking and elliptical trainer is good enough. There are muscle strengthening exercises as well. This is primarily for patients who are at high risk for falls, people that have poor balance. But elastic bands that you can get at, say, our local Dick's will work. And the National Osteoporosis Foundation website has some exercises that you can look up online to help you with strengthening your quads. Even just standing and rising up on your toes just to strengthen those muscles on your calves is actually good for you as well. Next slide. So I think this is also important. So if anything, when you go to your doctors for your regular physical, for example, and if you are in that age that I mentioned earlier, there are medications that can increase your bone loss. Steroids like prednisone, especially long-term use of prednisone. But if it's just like a 5-day course because you have bronchitis, that's not an issue. But if you have COPD and you have to take prednisone, say for weeks at a time, that can cause bone loss. Breast cancer patients that are on hormone treatments like Femara or Aromasin, because these are basically anti-estrogens, can actually cause bone loss. Surprisingly, heartburn drugs like Prevacid and omeprazole, if taken long-term, can also contribute to bone loss. I mentioned earlier excessive thyroid hormone replacement. So I have to stress excessive, not just any regular thyroid hormone replacement, but if you are getting too much, such that your TSH value is suppressed. Anti-seizure medications like Dilantin or Tegretol. And this one is also important, anti-diabetic medications like pioglitazone or Actos. Now, fortunately, this drug has not been really prescribed quite a lot now. It has been mostly replaced by newer and fancier drugs, but it also depends on insurance. It is still available in the market. I do try to avoid prescribing this drug to my elderly ladies, but sometimes if it's a cost issue, we got to do what we got to do. But this can contribute to bone loss. So if there's a way to switch diabetes medications, and if there are other options, we really try not to prescribe this to our older ladies. Next slide. So I think this is my last slide, but I think this is very, very practical. But around the house, just make sure that you remove all loose wires, place items within easy reach. I have patients like tripping on throw rugs. And if you're a person that lives alone, if you can have a family member, maybe get you some kind of a personal emergency response system. Use assistive devices like a grasping device to help you reach up on things that are, say, on the top shelf, that you don't have to climb up a step stool and fall. If in your bathrooms, it's a good idea to install grab bars on the wall, beside the tub, the shower, and the toilet. And then in the stairs, I think this is a good idea. You install light switches at the top and at the bottom, mark the top and the bottom steps with bright tape, install handrails on both sides. And then in the bedroom, I always tell my patients to try and keep a flashlight with fresh batteries on their bedside, and have a night light between the bedroom and the bathroom, and place light switches within your reach of the bed. And most importantly, if you are on blood pressure medications or somebody or your cardiologist started you on a new blood pressure medication, try and get up slowly from a lying down or a sitting down position, because sometimes patients do get dizzy and then that's how they fall. So just little practical things, but I've, had some elderly patients come to me and which seemed like not really a bad fall, but they fell because they fell off the bed, actually ended up fracturing their hips. And that's what we call a fragility fracture. So it is really very important that we take these little minor adjustments around at our house to prevent falls. And I think, Miriam, that's my last slide, correct? Yeah.
That sounds great. Let's see here. Okay, so that was the end of the presentation. If anyone has any questions for Dr. Mercado, feel free to put them in the chat or on our Q&A box, and I'll wait for just about a minute to see if there are any questions. Okay, so there's one question, or it's kind of more of like more of a statement, but so a lot of people, like I guess people my age, we feel invincible. We're like, oh, we don't need to worry about any of these things. Have there ever been cases where there has been a lot of like incidents of osteoporosis in like a younger population? And if so, what do we do about it? And are there, other than the things that you've already mentioned, are there ways that we can kind of work to prevent that or delay its onset from happening?
So if somebody has osteoporosis while they're still menstruating, and I like to talk about younger women, that are not technically postmenopausal, we don't really call that osteoporosis because by definition, that is only if you're postmenopausal. So we actually look for other causes of bone loss. If you are a person who fractured, not from a car accident, say, or not because you fell from a tree, but you say you just slipped and you had a fracture. So these are patients that we need to work up for other causes of bone loss and not just regular osteoporosis. So I have seen that, but to be honest, it's really not that common. I think if that happens, that is a red flag, which means we need to look for, say, a genetic condition, things that may be like those risk factors that I mentioned, if you're on steroids, that would increase your risk of a bone loss. But a person like us who still have our regular menstruation theoretically should not just fracture like that. And that means we have to work that up even more. So, yeah.
For sure. And you did mention autoimmune diseases. And so it is, a lot of people understand that people that already have autoimmune diseases, there was one, it's called ankylosing spondylitis.
Yeah.
I think,
so
what is there like a relation, and it makes sense that they should be more careful.
Ankylosing spondylitis is an autoimmune disorder, but I think it's more seen in like rheumatoid arthritis and in lupus, just because those patients, especially people with rheumatoid arthritis, they are on medications like steroids too. So it depends on the degree of the ankylosing spondylitis. If you are on the prednisone that I mentioned, and so that increases your risk as well. There's a lot of really nuances to that, but it's really identifying more than just the picture on the bone density, but just really looking at the family history, what your meds are, what other medical problems you have, and just kind of putting them all together is kind of sometimes the difficulty, because there's really not a lot of treatment for osteoporosis to choose from.
For sure. Awesome. I think that was all the questions. All right. Thank you so much, Dr. Mercado. This was a really interesting talk.
Thank you. Yeah.
For people that are kind of interested in wanting to know more about this When to Worry series or other topics by MHP or MAPS MCRC, please feel free to contact us at our websites and whatever contact info you feel comfortable using. I believe that's all. Thank you so much, Dr. Mercado.
Thank you. Bye-bye.
All right. Thank you. Thank you for listening in, everyone. Have a great day.